Good afternoon. On behalf of the Renal Association and the British Renal Society, we would like to welcome everybody to this webinar. My name is Marlies Ostermann and I'm a consultant at Guy's and St Thomas's Hospital, and I'm co-chairing this event with Claire Morlich, lead pharmacist at Lister Hospital. It's a great honor to chair this session because, as you will see, it will showcase what the specialist interest group Acute Kidney Injury is about, what it can do, and what it will promises to do in the future. We've got 8 expert speakers, and they will highlight the challenges and opportunities across primary care, secondary care, tertiary care, and spanning the full range from clinical practice to academia. Each speaker will take 15 minutes, and then there will be 5 minutes for questions. And I'd like to invite everybody to put their questions into the Q&A box at the bottom of your screen. Claire and I will then ask the questions. So without further delay, I'd like to invite Dorothea Nitsch, Professor in Clinical Epidemiology at the London School of Hygiene and Tropical Medicine and consultant nephrologist at the Royal Free Hospital, to present the highlights of the UK Renal Registry AKI report. Some of you will know her because she's well known to the Renal Registry and numerous papers which have been presented in the past. So Dorothea, welcome.
Thank you, everybody. Thank you for listening in. So I'm presenting the Renal Registry AKI report here, and this is on behalf of the entire Renal Registry who've all helped do this work. So what I will say is I'll show snapshots of the report. I will briefly explain what the AKI warning scores are and remind everybody about the algorithm, the methodology of the report, key findings. I will highlight ongoing data quality issues, and then I will summarize and say what we are doing next. So first thing, the AKI alert algorithm. Can you see my arrow? Yes. So the AKI alert algorithm, you can look at this in your own time. You can download it. It's a national patient safety alert in England. And essentially, if we go this complicated flow chart down, it first looks for a given creatinine, whether there was a previous creatinine on file. And if there was, it looks whether the 2 creatinines qualify for an AKI alert. Is the creatinine, is a tripling in creatinine, and depending on the ratio, these alerts are then sent to the Renal Registry and also to the treating clinician. If somebody never had a baseline creatinine in a lab, but they, for instance, have very abnormal values, a flag is sent to the treating clinician as this being an abnormal creatinine and requiring a retest. But these results, these single results of abnormal creatinines, are not sent to the Renal Registry. So what I'm going to present now is the UK Renal Registry Acute Kidney Injury report for 2018. And so what we used were the alerts that were sent to us from labs all over England, which you can see here. And some labs didn't send, for instance, correct NHS numbers, and therefore are rated red, or they did send otherwise incomplete data. So we had data that we could analyze for 87% of labs across all of England. So that's 166 labs. And that's in total approximately 1.5 million AKI alerts. These 1.5 million AKI alerts comprise approximately 490,000 patients in that year who had a bit more, 564 AKI episodes. And 3/4 of the patients had 1 episode, approximately a fifth or 17% had 2 episodes, and the rest had more than 2 episodes in the same year. So if we then look at variation by CCG, we drew a map for the labs where we had data that we could use, and some CCGs obviously have also labs where we couldn't use the data, or we only have partial coverage. And so each CCG was classified into whether we had complete coverage, i.e. we get data from all the labs in the or we only get data from some of the CCGs, or not, that we don't get decent coverage at all, which is red. And if we look at the incidence of AKI alerts for the green rated CCGs, where we think we get all labs in a given CCG, we still see a huge variation in AKI incidence. And I just want to highlight here a key finding, which is that the least deprived CCGs tend to fall slightly lower, they're yellow here, compared to the most deprived, which tend to be a bit higher here in terms of the alerting range. But you can see there is a huge variation in AKI incidence, and we wonder whether this is real or whether we still have an issue with missing baseline creatinines, because the labs don't necessarily share all creatinine values between each other at CCG level. So I was involved in an analysis institute at the time, and we pulled all the data from labs where we know that we have a complete coverage for a given geographical region, and calculated that. Now, these are smaller regions. This is not the entirety of England. So there were data sets from the Grampian in Scotland in different years, from Swansea and from Salford, where we could define precisely the population, and we had all the data from primary and secondary care. And you can see here the number of total AKI episodes, and we calculated the crude AKI incidence. And this varied from about 120 per 10,000 population to around 150 per 10,000 population. And once we standardized for age and sex, the variation was actually much less. It was around 140 to 150 per 10,000. And just to remind you again, for the UKRR data that we have in terms of AKI incidence, that ranges from 50 to 200 per 10,000. So we've got much more variation in AKI incidence than what we would expect if we had complete coverage for a given region. So if we now look at those alerts a bit more carefully, and we look at whether they originated in hospitals or in the community, we distinguish between three forms of AKI alert. We could identify patients who developed the hospital-acquired AKI, which is after 2 days being in hospital. One would assume that for all of these patients, there is a baseline creatinine on the system, because most patients, virtually all patients, get a creatinine on admission. And distinguish these patients from people who alerted either whilst they were only in the community and never entered a hospital, or who were hospitalized, but the alert triggered immediately on the day of hospitalization. And so hospital-acquired AKI is approximately 1/3 of all AKIs that we have on the system in the renal registry. Roughly 40% are people who were admitted to a with an AKI that probably started in the community. If we look at the age, on average, people a median age of 74 years. So most people who alert are older people, and roughly 50% are over 75 years. The group who have AKI only in the community and never make it to hospital are considerably younger. There you see that it's only 36% who are over 75 years old. Generally, children are a tiny group. They do not tend to alert that often. So it's about, overall for all AKI episodes, about 2%. Roughly an even split of men and women overall. And most alerts are stage 1, as you can see here. Obviously, the people who develop an AKI in the community and then get admitted to hospital are the ones who are more severe, and that's what you see here in the shift towards stages 2 and 3 being more common in people who get hospitalized after a community-acquired AKI. So if we now look at the mortality in these groups by stage, here we've again, the numbers, we've got the total numbers of alerts in each group, but the percentages here represent percent mortality, not percent of AKI. So if we look at the mortality, we see overall that there's very low mortality in people below age 40. It's around 3% if they get AKI, and that goes across all stages of AKI to 26% in people aged 75 or more. And this is even more pronounced if an older person gets stage 3 AKI, where it's then as high as 42% for stage 3 for very old people. Again, the mortality is roughly similar between male and female, slightly higher in men than in women, but that depends on stage of AKI. It's the opposite way around for stage 3 AKI for women. I'll discuss deprivation in the next slide. One thing I would like to highlight is that generally most alerts occur in January to March compared to the summer months, and that also mortality is highest in the winter months, in January to March, coinciding with the flu season. So if you look more at deprivation, there's a really important phenomenon. If we just look at the median age when people alert, according to deprivation quintile, where the quintile 1 is the least deprived and the quintile 5 is the most deprived, we see that the most deprived alert around a median age of 69 years, whereas the least deprived alert first when they are 77 years in median age. So there's a 10-year gap by deprivation status when people develop alert. If we then stratify by age group, we see that across all age groups in children, but also in the older ages, the most deprived within an age group are more likely to die. So for instance, here in the ages over 75, we see that the least deprived have a 25% mortality when they have an AKI compared to 27% mortality when they're most deprived. But what I find staggering is really if you just think about the age distribution across when people start triggering, and that's quite something. Oops.
Yes, so if you were to say...
I just tried to go back the slide. Yeah, if we just look at mortality by setting, the key finding here is that if you look at the percent who died by 30 days from AKI start, those with hospital-acquired AKI have a 23%, 24% mortality compared to people who alert in the community and never are admitted, with those who do need admission being a bit higher. And if you again look by the severity of AKI stage, people who develop hospital-acquired AKI and who have got stage 3 AKI, they have got a 36% mortality. So it's quite important, and we will hear more about this in the next talk. So some things about data quality and also clinician awareness. This is work from Manuela Savino at the registry, one of our registry fellows. And so she looked in people who had an AKI alert on our system and looked whether the hospital episode statistics, which are the codes entered based on the discharge record for a given patient, mentioned AKI or not. And if they mention AKI, then there's an N17 ICD-10 code on the system for that hospitalization. And so you can see for people who have an AKI 1 stage alert, it's roughly 50% who have an AKI diagnosis on the letter from the consultant. But with huge variation between trusts. The triangles here are the renal trusts with renal centers. The little yellow blobs at the bottom are the pediatric centers. And you see there's huge variation. Overall, on average, the percentage coded, i.e. mentioned on the discharge record, goes up with the AKI being more severe. And so that at least 80% of all AKI stage 3 alerts do appear on the discharge record for clinicians, with also less variation. But we definitely do not capture AKI stage 1 by looking at clinical records. Then the other thing you can do is you can compare the number of total alerts we have got on the renal registry system with the total number of hospital discharge records that NHS England knows about that have an N17 code. We only know the ones who've got alerts, and for those we can link the data, but we can't know the ones where we don't have an alert but they have an AKI. And so if I want to know, for instance, whether somebody without the baseline creatinine turned up in a hospital with a creatinine of 600 out of the blue, then I would capture them by asking for these extra codes. So we did that, and we found something quite staggering. We found a huge variation between labs at given trusts on whether they had N17 in the discharge record or not. So for 3 labs, for instance, the ratio between AKI alerts to the total number of N17s for that trust is about 60 to 79%. And we then went back and looked, and there were definite issues around the way the data were extracted and or sent to us or the system alerted. So this is a good way for us to better understand which bits of the data are not that good. Generally, most labs have ratios of more alerts than N17 codes, which is what we would expect given what we know about coding. Okay, so let me summarize. So the known knowns is we've got around 1.2 to 1.5% in annual incidence in the general population. That's really common for an acute disease. If people get AKI, it's associated with a high mortality, 3% in people aged below 40, but very high for people aged 75 and over. There is seasonal variation, both in incidence and mortality, with winter months being worse. Older people, and especially those who are more deprived, are more often affected by AKI, and you can see a trend across deprivation groups in each age stratum. Hospital AKI is not a good news for patients. There's considerably higher mortality than community-acquired AKI, and we will hear more about the variation in the hospital-acquired AKI mortality. So what do we not know? Well, one thing I worry about a lot is that we might not capture all community-acquired AKI due to a number of issues, maybe because of a missing baseline. Say one lab looks after patients who are seen by GPs, and another lab looks only after outpatient records, but not patients seen by the GP, and then you don't get alerts. There are issues around lab coverage. There are issues around local data extraction, and once we understand these, we will hopefully understand the variation in incidence, which we think is in parts artifactual. We do not know how a local AKI incidence relates to subsequent RT incidents, but we are working on this. We've got an MSc student looking at this right now as we speak. If we would understand that, then we would have some indirect grasp on how AKI related to COVID might impact later on dialysis incidents. But we also have linked the AKI data directly to the COVID data held at Public Health England. And so we hope to be able to understand a bit more about AKI in the context of COVID and outcomes later on. So thank you very much for listening, and I look forward to getting questions about this. Thank you.
Dorothea, thank you very much for summarizing everything so well and highlighting obviously the key findings, but also the challenges which we still have. Your talk was very clear. There are currently no questions in the Q&A box, and therefore I would, if possible, like to ask you to stay because questions may come up during the session. And if people have questions which relate to this report, they can maybe pose them during the session and we ask you later, if that's okay?
Yes, that's fine. Also, the report can be downloaded from the UK Renal Registry website under the reports tab. So it's a public document.
Perfect. So I then like to hand over to Claire.
Okay, thank you very much, Molly. Thank you very much, Dorothea. Right, so next we've got a talk from Will McCain on what GIRFT tells us about AKI care. Will is, as you probably all know, is a consultant nephrologist at Sheffield Hospital, where he is the lead for transplantation. He's been a member of the NHS England CRG for renal for a number of years, and he's also the code lead for the renal GIRFT report. So thank you very much, Will.
Presenting this on behalf of myself and Graham Lipkin. We're co-leads of the Getting It Right First Time renal work stream. I don't want to spend too long talking about what GIRFT is, because I feel as I've given that talk to a lot of people a lot of times. But in summary, it's a data-driven peer review process where we pull together data from a whole load of sources and we put it into a data pack. And then we actually go and visit the centre itself. So Graham and I have been to all 52 English renal centres. It's purely in England, this process at the minute. The peer review is meant to be a kind of open discussion, non-critical approach, which helps centres identify what they're good at, which is important, but maybe where their outcomes are not as good as they would like to be. And there has been some criticism of GIRFT in the sense that as a quality improvement project, it can be perceived as quite top down. And I think most people would believe that bottom up quality improvement programs work better. And I think that has some validity, but I think that the deep dives where we actually meet people with chief executives and medical directors in the room, on the whole, have had value for centres, and we've got benefit from it. So not surprisingly, we were asked to look at AKI as part of this process, but the first thing we sort of observed was that not very much hospital AKI care is delivered by a nephrologist. So this figure here of 1% is from registry work, not done by the GIRFT team, done by Winnie actually, showing that only 1% of those hospital-acquired AKI alerts that Dorothy has been describing happen whilst a patient is under the care of a nephrologist. And 2/3 of them happen under acute medical specialties. And just over 10% of them have some critical care involvement during the admission. It doesn't mean the alert happened when they were on the critical care. So we were conscious that we were sort of doing a peer review about an area of medicine where actually we're not delivering most of the care. However, it is also true that in many hospitals, nephrologists are providing quite a lot of clinical leadership as our critical care physicians for AKI care. So we thought it was appropriate to look at AKI. In fact, acute medicine GIRFT have also looked at AKI as one of their sentinel conditions. So what I'm going to talk about is the descriptive findings from those meetings, those going to the 52 centres. Then I want to talk about the metrics that we've been working on from this linked database of the Master Patient Index and the hospital episode statistics that Dorothea was talking about. And we've had 2 GIRFT fellows working for a little bit under a year now at the registry, one from a data science background, David Pitcher, and one from a clinical background, Javeria Paracha, working on metrics where we focused on mortality. We're interested in inter-hospital transfer, although that's more difficult to look at. We're interested in length of stay. And as Dorothea has said, incidence is the most difficult of these because it's quite difficult to be confident that you're capturing all the data. And for hospital-acquired AKI, where you may be more confident you're capturing all the data, we haven't had the HES feed on all the patients that don't get AKI. So I'm going to concentrate on mortality today, and then I'll briefly talk about what is likely to be in our national report. So when we went to visit trusts, we chatted to them and we asked them questions. And I guess we were slightly surprised that even in trusts with a renal centre, not all of them have any kind of local written protocol or guideline for the management of acute kidney injury. Now, I'm not suggesting that writing a protocol solves everything or delivers the quality improvement. Of course, it doesn't. But if you haven't got anything, if you haven't got any framework to base your service on, I think that makes it less likely to be a good AKI service. And one imagines if you went to all acute trusts, not just trusts with a renal service, that figure would be a bit lower than that. About 1/3 of the renal centres in England at the time of our visits, which were in sort of 2018, 2019, had an AKI, generally a specialist nurse workforce, although one or two centres have other professionals involved in the workforce, where these AKI nurse specialists were not just working in the renal unit, they were supporting the AKI effort in the whole trust. And the structure of those teams is very, very varied. So in some trusts, for example, that team is purely providing education support. So they're going to wards that admit patients acutely and have acute inpatients and providing education about how to identify and manage acute kidney injury. Whereas in other trusts, they were actually getting much more directly involved in managing, in supporting teams on non-renal wards to deliver AKI care. Now, and in a few trusts, delivering dialysis support and acute dialysis prescriptions. Now, some trusts have chosen not to design their AKI team like that, and they have often linked it in with critical care outreach teams, and I'm sure you're aware of that. And one or two trusts sort of said, well, actually, we want everyone on all our acute wards to be able to identify the acutely unwell patient, and we see AKI as part of that process. And we don't really want it to be the preserve just of the renal service, which I think is a perfectly defendable position. Now, the term AKI network is not really particularly well defined, I don't think, and obviously it really came into focus in the COVID period, but our peer reviews will all perform before COVID. But I think it'd be fair to say that these have a great variety of maturity. There are not many non-renal trusts that have nephrology presence every day. And it's very, very variable how much nephrology presence non-renal trusts have. Some renal services have invested quite a lot of time and effort in this and have a lot of outreach work, and they link it into outreach work in outpatients and dialysis care, and some less so. One thing that I think seems to be very valuable are an increasing number of acute posts in acute medicine that are hybrids. So these are people who are trained in renal medicine and acute medicine, who are employed in acute medicine in a non-renal trust, but who have an AKI leadership role and also act as a link person to renal services. And everyone that had that kind of post or linked into that kind of post reported it as very valuable. I can't show you any formal measurements on the value, but everyone reported it as valuable. And then there are one or two trusts who are linked often to large tertiary cardiac services where they're not co-located with the renal service, but there's a lot of AKI, where the AKI nursing specialist team is actually working in the cardiac center to provide AKI support and dialysis. And then this was something that was of great interest to Graham. You know, urgent access to nephrostomy is a very narrow area of AKI, I appreciate, but it is in the National Service Specification, but only 50% of centers, of renal centers, have reported 7-day access to nephrostomy. What about transfer of care? So 73% of centers reported delays in transfer of care, and all of them considered it likely to adversely affect outcome. And I think that tells you a lot about the pressure on that portion of the AKI pathway that is being referred into the nephrology service. On the other hand, it wasn't 100%. So clearly there are some centers that are able to transfer people in a timely manner. Quite a lot of centers and networks had an agreed transfer protocol. This is about the safety of step down from critical care, but you can see it wasn't everywhere, and it was just over half. And then we started trying to look at how common transfer was. So if you look at all the hospital-acquired AKI alerts, you find that about 6% of them have an alert prior to an inter-hospital transfer. This is looking at hospital episode statistics. And I thought it would be really easy to track what proportion of these end up in renal medicine. In fact, it's really very difficult. So I'm not going to try and tell you any more about that at the minute, but hopefully that will be something we can answer in the future. And not surprisingly, because there are delays in transfer, there is a significant use of critical care beds for renal support in patients that don't otherwise need to be on a critical care unit. We've got a big data blind spot, which is dialysis delivered for acute kidney injury. We could derive data on this from 3 sources, either from the HRG, so from activity reporting. Very few centers are using this HRG, and it doesn't have a fixed tariff attached to it at the minute. we could look at AKI HD reported to the registry, but not that many centers are reporting. And we could look for a dialysis procedure code in hospital episode statistics and link it to a diagnosis of acute renal failure, N17, or link it to an AKI alert. But none of these data sources are complete, although the last one is the one that's used in some very valuable publications from the Derby group on this question. So we looked at N17 codes, and then we looked at the first dialysis in a patient with an N17 code. And on the left, we looked at the interval between admission and the first dialysis in trusts with a renal hub. And we looked at the interval between admission and the first dialysis in trusts without a renal hub. And you see there's a big difference there. And of course, it doesn't tell us what's causing the difference. Some of it may be entirely clinically appropriate. It would be entirely clinically appropriate to stabilize a very unwell patient in a critical care area before transferring them for dialysis. So that would be clinically appropriate. But there may well be delays in identifying acute kidney injury or the severity of acute kidney injury in the referring hospital. And there are certainly delays in the receiving hospital being able to accept patients with acute kidney injury. And we consider this to be a real problem and a measure of lack of capacity in the system. And then this is pretty old data from ICNARC. I'm not going to waste time on it, but showing that there are some critical care units where there's quite a lot of bed occupancy, which is purely about delivering renal support and nothing else. Of course, not all of these patients are AKI. Some of them are end-stage kidney disease patients that are admitted to non-renal centers for other reasons. So Dorothy has kind of provided a little bit of introduction. GIRFT is really interested in center variation. How does one center compare with another, and is there unwarranted variation? So our mortality analysis focuses on hospital-acquired AKI, and it looks at deaths in hospital and up to 30 days after discharge. And the reason we've adopted that approach is because that's what SHIMI does. Now, I know that SHIMI has its critics, but SHIMI is the NHS digital adopted method for reporting mortality in acute centres. So we adopted that broad methodology and adapted it. And we developed a mortality model which is case mix adjusted. I'm not going to read all these out, but you can see the things we've adjusted for. But I'm just going to focus on this one, that in SHIMI, patients are divided into 142 diagnostic groups based on the diagnostic codes. And then secondly, a lot of work went into, and I'm not going to show this data because there isn't time, into re-weighting or rebalancing the comorbidity score so that it was one that was appropriate to and meaningful to patients with AKI. So pretty detailed work. There are some interaction terms in the model that I'm not going to go into detail of. But what you will notice is that ethnicity and deprivation are not in this model. They're not in SHIMI either, so we were faithful to that method. But clearly we're interested in ethnicity and deprivation, and I will show you some data on that as well. So this is Dorothea's slide really, and it's quite complicated. So each dot is one of those 142 diagnostic groups. And on this axis here, you can see the mortality. This axis here, you can see the mortality in patients in that diagnostic group if they had AKI. And on this axis, you can see the mortality in all the patients in that diagnostic group, whether they had AKI or not. And these are unadjusted data. And it's a log-log plot, because otherwise you can't fit it on one screen. And if they're left of this line, then the mortality is higher if the patients have AKI. If they're left of this long dashed line, then the mortality is at least twice as high. And they're left of this short dashed line, then the mortality is at least 10 times as high. So this is an incredibly striking picture to show that the mortality is absolutely consistently higher, whatever the diagnosis. And I don't think that would surprise many people, but actually what might surprise you is just it is 10 times higher or even more than that in many of these diagnoses. So this is the final product of the adjusted model. Actually, the model's undergone a few iterations since then, so it's not quite the final, but it gives you a pretty good feel for what we're looking at. This is just for patients with AKI 2 and 3, because that's what will appear in the GIRFT report. And I think we're quite happy with this in the sense that the data don't look too dispersed. most centers have mortality for AKI that is with a standardized index of around 1, but there are a handful of centers that are beyond the 95% confidence interval, and there are a few centers below the 95% confidence interval and one below the 99.9. If I showed you the plot for AKI 1, 2, and 3, you would see a little bit more dispersion. Because the model is complicated and there are many interaction terms, I can't show you the odds ratios for every single possible combination. Otherwise, you would metaphorically shoot me by Zoom. But there are here a few selected ones. So if you're admitted as an emergency rather than elective patient, your mortality is 3.5 times if you have AKI. The mortality in males in this adjusted model of hospital-acquired AKI is higher, actually, 30% higher. And not surprisingly, the mortality in AKI 2 versus 1 or 3 versus 1 is roughly twice as high. I think what maybe surprised me more is that there isn't so much difference. It does reach significance, but there isn't so much difference in mortality between 3 and 2. And then for age and the comorbidity score, you get an increment in both in mortality as you increase age and as you increase comorbidity, irrespective of the interaction terms. And I'm not showing the seasonality data, but it is confirmed in this analysis as well, which gives us kind of confidence that it's working. So I did say I would talk about ethnicity because a lot of people have asked me about this. So this is the unadjusted hospital and up to 30-day mortality by ethnicity. And what you can see is that actually the highest mortality is in the Caucasian patients, and the non-white are the BAME patients. And we've got some missing data, although the amount of missing data is reduced since this initial analysis was done. It is actually lower. And then it's quite small this, but in the full model, which now includes deprivation and ethnicity, again, this is borne out that the odds ratio for dying for Asian versus white and for black versus white is around about 0.8. I'm not going to talk about length of stay. We're working on length of stay. I think we'll have lots of interesting data to show on length of stay, but I just was going to, this graph is from the AKI report, so you can all spend time looking at this. But we know from the TACI study that with quality improvement work, you can reduce length of stay. And if you were there are an awful lot of admissions complicated by AKI. If you could replicate TACI across the whole of the 500,000 admissions with AKI, you could potentially, this is a notional efficiency figure, it would be a big figure. And actually it would dwarf any of the other savings that we could make in GIRFT. So it's really, really, in renal GIRFT, so it's really important. And then finally in the national report, I don't want to spend long on this because I should wind up, but we've got 2 recommendations in our national report about AKI. One which is applied to all trusts, which is really just saying that all trusts need to take this seriously. It's reinforcing that message, which is clearly already a very strong message. We didn't want to reinvent the wheel. We think that the NICE guidance provides a good starting point. We think that care bundles are evidence-based, but we think if we could produce better data, get that data validated and have it in the model hospital in the public domain, that might also help trusts with their quality improvement efforts. And then secondly, we do feel this issue of capacity and inter-hospital transfer is important at the very severe end of AKI where nephrologists are involved. And we're keen to kind of strengthen the commissioning requirement to make this within 24 hours and to make networks deliver that and to provide money to pay for dialysis that supports that's supporting AKI patients. And that's all I've got to say. Thank you very much. Now, a lot of people contributed to this. And they're all listed there, but I've highlighted in particular Javaria and David, who have been working on the data set extremely hard. Thank you.
Lovely, thank you very much, Will, for a nice whiz through what the GIRFT actually showed us. And it was quite interesting. I thought that, again, looking at emergencies and ethnicity and etc. plays a role in here as well. And it's proven in the GIRFT as well, hasn't it? We actually haven't got any questions. We've had one for Dorothea, which perhaps we'll bring out at the end, but no other questions at the moment. So, Marley, should we move on to the next presentation?
Sure. So far we've heard fantastic presentations highlighting the fact that ICAR is very common and that it's serious and has implications for not only the patient but healthcare in general. And it's very clear that a lot of people are involved in looking after patients with AKI. The next presentation will highlight this. So it's a presentation highlighting the multi-professional input, and clearly it needs to be given by multi-professional people. So we have a team of 3. Claire Morledge as the lead pharmacist from Lister. We have Claire Main, a lead renal nurse from South Wales, and Danny Bear, principal dietitian at Guy's and St Thomas's. So over to you, Claire, highlighting the importance of multi-professional care.
Indeed, thank you very much, Marley. So as we've said, that we thought we'd bring into the mix, as well as looking at the multi-professional team that are involved in AKI management. And this is both all the time, and particularly highlighted during the COVID period, which we'd just like to bring into that as well. So I'm the lead renal pharmacist at Stevenage at Lister Hospital in Stevenage. I'm also the chair for the renal pharmacy group. And pharmacists have had a big role, obviously, within AKI, and also during the COVID period as well. So as with all AKI patients, all medications should be reviewed, and we need to look and see if it's a nephrotoxic medication or a medication with a nephrotoxic potential. We should be stopping that medication and reviewing it at a later date. All medications should have their doses optimized to the current renal function. And that brings on always to a little bit of a debate. What should we be using? Well, creatinine clearance is the method of calculating what renal function we should use in order to tailor doses. We know it's not very accurate in rapidly changing renal function, and again in acute kidney injury that is often the case, but it's the best that we've got, and it's what the drug companies have used in order to dose and their medication. So that's what we should be using in order to tailor doses to the patient's renal function. We need to remember to change these doses even daily as the renal function changes, and we need to remember to plan and communicate when to reintroduce those medications when the patient is discharged. We also need to add a little bit of thought behind the doses that we recommend, and looking at the patient's clinical situation as well, and not necessarily reducing the dosage straight away if the patient's highly susceptible and that we need to be treating them with antibiotics. Communication and planning is key to the majority of this. Renal replacement therapy has caused a few discussions during the COVID period. So medication doses need to be adjusted when renal replacement therapy is started or stopped. We also need to consider what type of renal replacement therapy that is. Is it CVVH or CVHD, or are we using SLED or SLED-F or intermittent hemodialysis? So all of those different forms of renal replacement therapy, you need to look at the dose depending on that. So it's important to know how much of the drug is removed by that renal replacement therapy and what we're going to do. Is there any evidence out there, or are we looking at the basic pharmacokinetics for the medication and making a best guess at what we should be doing? If the patient's on intermittent renal replacement therapy, again, we need to think of the timing of the doses. So we may need to do different doses on different days, depending on when the patient's dialysing or not. And remembering that if the dialysis is started or stopped for other reasons, like clotting of the access, we need to make sure that we are amending doses in comparison to what's going on with the patient. We also need to think about which sort of filter is being used, especially for intermittent hemodialysis or for SLED as well in particular. Are we using high flux filters or are we using low flux filters? Because obviously that's going to affect the drug removal through dialysis. And majority centres for intermittent hemodialysis, we use high flux, but what are we using with SLED-F, and what does the evidence actually show us as well? A lot of the papers look at SLED and look at low flux, but actually we're using high flux filters, so we need to think about that as well. So we've had lots of dilemmas and lots of thought around the different doses and what should we be using in these patients when they're on renal replacement therapy. And now I'd like to hand over to Claire, who will talk through the nursing side of it.
Thank you. So my name is Claire Main. I'm the lead nurse for nephrology and transplant in South Wales. And as Will has already pointed out, it's quite unusual actually for the AKI patients to end up in the nephrology renal wards. So this is very much thinking about how to work in collaboration. And as Claire has said, particularly through the COVID period, we've had to work much closer together with our colleagues across many different specialities. And we've also had patients who've appeared in lots of different areas that may be unfamiliar with AKI or recognising it. So I've split that up into two parts really. I think one of the main areas to look at is obviously for the patient to be fully informed about what's happening to them. And I think as nurses, it's really important that we help to support that information process for them. So particularly with the AKI, the information can be really complex and it can change really frequently. So patients may have come in for a completely different reason and developed AKI while they're in, or obviously may have come in for the reason of AKI. The way that they're managed and what happens to them changes frequently, and it's important for us to make sure that we're fully briefed on that so that we can make sure that the patient understands what's happening, not only now and at the very moment that they're in hospital, but also potentially what the future may hold for them. People may start talking about acute on chronic renal failure, long-term prognosis, treatment choices, and that can be quite scary and overwhelming for somebody who wasn't aware of any of this before they came into hospital. I think it's also important to make sure that the family and the carers are aware and include them, obviously with the patient's permission, in terms of what's happening, particularly if there are elements of the patient's history or previous medical reasons that may have contributed to the AKI that they need to be aware of to support that person. One of the important things to think about is the patient's ability to understand and retain all this information. Obviously, as we're all aware in a renal field, particularly when patients are suffering with uremia, it's really difficult to retain information or to hold on to what's going on or to remember things. So I think it's important to keep revisiting with the patients their understanding of what's happening, and also to make sure that that's clearly documented and understandable to everybody so that there's a consistent message. The other thing is that these patients may move around, so they may transfer between renal wards, sometimes critical care areas, and then back to surgical or medical wards. So it's to have that consistency of messaging for the patient so that things are stable for them. In terms then of moving on to looking at what happens from a nursing perspective, again, I think because a lot of these patients are sitting on wards with nurses whose renal function isn't the main priority for some of these areas, it's really important to help support the nurses that are looking after them. And some hospitals are lucky enough to have AKI nurse specialists who will support that education and overall monitoring of patients, but not everybody does. And obviously, particularly in extreme circumstances such as we had with COVID, resources are stretched. So it's important that everybody understands what's happening and takes ownership of this part of the patient's medical problems. So a lot of this is related to understanding exactly what's happened to the patient and potentially trigger factors that are in their background that may have contributed to the AKI or leading to sort of some of the chronic underlying conditions, and also helping to understand if this is a new condition for them in terms of what's happened to them while they're in hospital, or if this is the reason they've come into hospital, some of the contributing factors with that. Obviously, one of the key things from a nursing perspective is to monitor the patient's fluid balance. I'm a big believer in involving the patient as much as that, with that as much as possible. So if they're able to, for them to help to record their fluid balance and understand why we're doing it and what's going on, it's a really good way of educating the patient about what's happening. If either we can't maintain a fluid balance, or if we're not sure that it's accurate, if the patient's moving around a lot or they're moving, not on the ward a lot, then daily weights are an alternative and a supplementary piece of information. And again, I think the important thing is to make sure that we're not only looking at the daily patterns, but also that 24-hour sort of cumulative total to get a real feel for what's happening to the patient. And again, if it's difficult to record fluid balance, it's about making sure that we've thought about all the options. So maybe catheterizing the patient for a short amount of time to capture fluid balance properly. And also to make sure, particularly from Claire's perspective there, in terms of any other additional fluids that are happening. So it's not just what the patient's taking in, but also thinking about drugs, fluid volumes with that, and moving on to afterwards in terms of food intake as well. It's really important with these patients because their condition can change really quickly. So to make sure that we're observing them regularly and escalating quickly as well. So being aware that you've either got a patient who's got signs of AKI or has got diagnosed renal failure, that actually we're making sure that people are aware of them and they're being escalated quickly because their condition can change. As I've already said, there's a lot of movement for these patients. Often they're either being moved between ward areas depending on their condition, or because of needing further dialysis treatments or other care, they're moving around. So it's to have that consistency, not only for the patient, but also for the other staff that are looking after them in terms of what's happening, underlying issues, and the next steps for them to keep that consistency moving forward. And finally, particularly for the ward areas, it's understanding if the patient's having any form of renal replacement therapies, or if they have had done, what the implications for the nurses who aren't delivering the renal replacement therapy is. So understanding if medications have to be stopped, if they shouldn't be given before treatments, if there's any fluid restrictions, and to help again the nurses who may not be familiar with dialysis to understand the implications of that, and also the fact that particularly during the COVID period, we did start to implement different types of treatments that may need more education and may need further development from that. So that's a very sort of potted history from a nursing perspective then. So I'll hand over now.
Great, thank you so much. I'm Danny Bear. I'm the Principal Critical Care Dietitian at Guy's and St Thomas's NHS Foundation Trust in London. And I was asked to give the nutritional considerations for the management of the critically ill patient with acute kidney injury and put a little bit of a COVID spin on it. And I think this MDT session's really important because I think COVID really highlighted the importance of the MDT working together, and particularly in regards to nutrition. Claire, if I could have the next slide, please. Thank you. So ICU patients are at significant risk of very early and very rapid muscle wasting. And this is always worse in patients who are much sicker and who stay for longer on the intensive care unit. And this just happens to be those patients who do have acute kidney injury who do tend to stay for longer on the ICU. So we do see a significant amount of muscle wasting. And this is exacerbated by the underfeeding that we see quite frequently in patients on ICU. A lot of the time because of interruptions to enteral feeding, because of procedures that might be going on at the bed space, or because they are not necessarily tolerating their enteral feed. And during COVID, that was a real problem, particularly the patients missing out on their feeds frequently because of regular proning, or maybe having a lot of staff around who were unfamiliar with local feeding practices. So we did see a significant amount of underfeeding and exacerbating the muscle wasting that we already see. So as dietitians, what we need to consider with these patients is what is the management strategy for the acute kidney injury? So what I mean by that is, are patients going to be receiving continuous renal replacement therapy, intermittent renal replacement therapy, or no renal replacement therapy at all? Because that might then go on to change our plan for feeding that particular patient. On top of that, we have to consider in our plan the non-nutritional energy sources that the patients receive for a lot of their ICU stay. So for example, propofol is one of them. For those of you who don't know, propofol is given in an intralipid base, and that contains 1 calorie per mil. So that can go on to contribute around 700 or 800 calories to the patient, even without considering their enteral feed. And then when we account for that by reducing the enteral feed, we inevitably reduce protein intake in these patients. And again, during COVID, we saw this as a real problem because we ran out of 2% propofol, so had to use a lot of 1% propofol. So we did find that it was much more difficult to meet patients' protein targets because we were having to reduce the calories that they received from their enteral feeding. We also take into consideration the calories that are contributed from citrate anticoagulation. We would then think about micronutrient losses on renal replacement therapy, but I won't focus on that today. And we would think about fluid restriction. Again, during COVID, fluid restriction was a real problem and did make it a little bit more difficult for us to meet patients' energy and protein targets, because we had to put patients on a more fluid restricted feeds, and they tend to also be lower in protein. And this was particularly the case for patients who were sharing renal replacement therapy machines when we were running low on them, for example. So we did have to think a little bit outside the box in terms of making sure that we were able to meet the nutritional targets of the patients. And along with this fluid restriction comes the management of electrolytes, which as dietitians we would consider in our nutrition plan. So that's the nutritional considerations. Claire, if I could have the next slide, please. I'll talk you through some of the strategies that we use normally and did prove to be quite useful during COVID. But the first thing that I want to say is that nutrition is a team sport. So although the dietitians do tend to be the ones leading the advocacy for good nutrition in the ICU, every single member of the MDT can play a role in making sure that we do improve the nutritional delivery in these patients and that they do get the best nutrition care. And one of the things that we tend to focus on is making sure that no matter the treatment modality that we're using for the acute kidney injury, that patients receive high protein enteral feed or parenteral feeding options. And some of you might think, well, actually, we tend to go for lower protein in these patients, but we know that they miss out on a significant amount of enteral feeding. So we tend to use the higher products and still only get just to the target that we're looking for. So we do that as a proactive rather than reactive approach and find that that works really well, and particularly worked well during COVID to make sure that we were able to meet the targets. We tend to limit the use of fluid and electrolyte restricted feeds to only patients who are on intermittent renal replacement therapy or were sharing renal replacement therapy machines or not on renal replacement therapy, because they are lower in protein. And we do find, because of the low electrolytes, the nursing staff end up having to chase electrolyte supplementation quite a bit. And so we do tend to limit the use of those feeds where possible. And the other consideration for the whole team is really just to be conscious of minimizing feeding interruptions where you can. So if you know that the feed has been off for a significant period of time, perhaps because the patient's going to have a procedure, just being mindful that we need to be restarting that enteral feed as soon as it is feasibly and safely possible. And the final point in all of this really is just to monitor the patient. And we look at what we're aiming to feed the patient versus what they actually receive. And we try and do that at least twice a week so that we can keep on top of their feeding schedule and make sure that we're able to meet patients' protein targets and energy targets and avoid overfeeding in that regard. But again, this can also be a very big team effort to make sure that the patients are fed well during their ICU stay. Thank you.
Okay.
Fantastic. Thank you so much for highlighting the MDT approach. And you've also generated quite a lot of questions in the chat box. So there's one question, I think it's for all three of you, and maybe also for Will, and it's a general question. Given the fact that AKI is associated with mortality, are there any modifiable factors, and are there any management factors which may influence and potentially reverse the outcome of AKI? So are we contributing to AKI, and more importantly, could we change the outcome of AKI? Maybe Claire, do you want to start? Claire Morledge?
I suppose what you can do is look at the fluid that you're putting into the patient, can't you? Trying to change the outcome of it, looking at the fluids, looking at the medication that you're using, trying to not give any other reason for any renal damage as well, I suppose. Making sure that if you use it, trying not to use any nephrotoxic medications or anything that's going to accumulate and cause the patient any other problems. And that would be one way of trying to prevent medication from worsening or prolonging the AKI.
And Claire Main, do you think there's anything the nurses can do to improve the outcome of AKI once it's occurred?
I think a lot of the work that we're doing is looking at education and observation. So a lot of it is early warning signs. So particularly looking for signs of dehydration for patients that may develop AKI while they're in hospital. So particularly those vulnerable groups of people who may not be able to access fluids and nutrition independently, and looking for signs of dehydration that way. I think a big thing, you know, for any ward that you're working on, making sure that you're keeping a really close eye on people's observations, fluid balance, and a holistic picture of any changes in the patient's condition is really important. So I think anything that we can do to try and pick up early warning signs of a deteriorating patient is helpful. And one of those early signs is often an AKI that can be reversed if it's picked up quickly then.
And Danny, do you think nutrition could reverse the outcome in AKI?
I certainly, well, one of the points I was going to make was also about fluid. But when thinking about patients with AKI who are on the ward or who are early in their ICU admission, I think making sure that we're addressing any nutritional deficiencies early could potentially improve outcome of AKI patients, because we know that patients who are malnourished are at significantly higher risk of mortality and morbidities. So I think making sure that there's early nutrition interventions and early dietetic input, regardless of whether the patient's on ICU or the ward, could certainly potentially help to influence the outcomes going forward.
Thank you. There's one more question which may be quite useful, although we're almost running over time, but it's a question about the AKI specialist nurse, and I maybe ask Claire Main about this. You pointed out that patients may be on other wards. They may be on a ward which is not familiar with AKI. Do you think there is a role for an AKI nurse specialist, and what would they do, and would they replace a nephrologist?
They certainly wouldn't replace a nephrologist for fear of offending many people on the call. And it's very much in terms of an MDT approach to these patients. But we've recently developed AKI interest nurses within our outreach team from critical care. So again, as Will mentioned in his talk, there are various models of doing it. So I can only talk to the one I'm familiar with, but certainly it was one of the areas that we noticed, particularly recognising the deteriorating patient. One of the early warning signs before probably we use the early warning scores to identify those patients, but actually we implemented the AKI alerts on the patient's blood results, and actually that was an earlier indication of a deteriorating patient than necessarily the score itself would pick up. So some of the outreach nurses have developed then on the back of that tools to help identify education elements of that. So once an AKI alert is picked up, that means that the outreach team visit that patient on whatever ward they're on and then implement a series of education measures. As part of the outreach team, obviously then they're picked up in terms of appropriate medical referrals and support independently of that. But the AKI nurse role in that particular element then is educating the nurses in terms of what to look out for, the importance of all the things I've mentioned in terms of managing that patient, and also the communication and regular follow-up. So we've certainly seen an improvement then in actually picking up patients who then hopefully don't need to move to a critical care or more high dependency type area, because they're being managed more appropriately on the wards and we've been alerted to them much quicker. So some of those never actually see the nephrologist because they're picked up because of, you know, simple things like I was saying about dehydration, things like that, that are actually easier to manage from a medical side then.
Thank you, Claire. There are many more questions. It's about drug dosing, about overfeeding, about cost savings with an AKI nurse. I would be grateful if maybe all of you could type their answer so the attendees can then read the answer. Otherwise, we will completely overrun.
Yeah.
And with that in mind, I need to hand over to Claire again. Thank you very much for the presentations.
That's okay, thank you, Marlies. So the next presentation is by Dr. Charlotte Summers, who is a university lecturer in intensive care medicine at Cambridge University. She's been involved in a lot of the COVID response studies, and she's often in the paper on TV commenting on research studies that are in progress. And Charlotte's going to talk to us today about current treatments for COVID-19 and the evidence base. Thank you very much, Charlotte.
Thank you very much to Claire and Marlies for asking me to talk. I should just explain that my background, so I dual trained in respiratory and intensive care medicine, and currently do clinical practice in the ICU, but have been involved in a lot of the national work around developing therapies for COVID, partly as working with UKRI and the CMOs around what therapies we should be considering for the clinical trials. I think the first place that I would start is to say that this is a new disease. Before Christmas, pretty much none of us had ever really heard of this particular virus, so we're starting from scratch, and as that we've got things that we've known from the past about how to look after patients with supportive care well, but in terms of therapy for this actual disease, we didn't have anything. A whole plethora of people from across the world have come up with their favourite idea about what should be the right therapy for COVID. And I think the important thing, and my personal point of view, is the one that the CMO has shared with everybody, and this is from his first letter that he wrote to all trusts, saying that actually this is a new disease, we don't know what works, and therefore everybody we could should be recruited into the clinical trials, and the off-licence use of treatment is strongly discouraged. And we might come back to that a little bit later in talking about convalescent plasma and the happenings of the last week on that front in America. But across the globe, a lot of therapies have been given because people thought they were a good idea and they felt they didn't have equipoise, they were sure they were going to work. And every time we've done that, we have lost the opportunity to learn something that might save many lives in this disease. And if you remember nothing else I've said, remember that actually research and randomisation are really important to finding efficacious therapies that we really have an evidence base for in this new disease. So what have we done? In the UK, there's been the recovery trial, about which a lot has been written, but I thought I would give some basic facts. It's a national clinical trial to identify therapies. The current arms that are open are low-dose dexamethasone, which is only open in children, azithromycin, tocilizumab, and convalescent plasma. And they have produced results so far for hydroxychloroquine, dexamethasone, and lopinavir/ritonavir. The hydroxychloroquine and lopinavir/ritonavir results have shown that those medicines didn't work. So I thought I would just speak to you about the one that looks like it might do, dexamethasone. So dexamethasone from the BRS study was, I don't know what's happening there. It's just, the dexamethasone study has been published, the preliminary report, in the New England Journal, and it was a controlled, open-label, randomised trial in hospitalised patients with clinically suspected or lab-confirmed SARS-CoV infection, and the majority of the patients, so about 80% of them, actually had confirmed SARS-CoV. It's part of a platform trial, and the patients were randomised 2-to-1 to usual care, or dexamethasone 6 milligrams once daily for 10 days until discharge. And the primary outcome was all-cause mortality within 28 days. The secondary outcomes were time to hospital discharge, invasive mechanical ventilation, and death. And they're the same endpoints for pretty much all arms of the recovery platform. For dexamethasone, 2,104 patients were randomised to the intervention, with 4,300 or so to usual care. 90% in this particular arm had SARS-CoV infection confirmed. At randomisation, 16% of them had mechanical ventilation, 60% were receiving oxygen with or without NIV, and 24% were receiving neither oxygen nor ventilation. The use of other therapies was fairly low alongside this, so there was about 25% of azithromycin that wasn't different in the arms, but almost no one was receiving hydroxychloroquine, the other antiviral therapies, or IL-6 antagonists. And remdesivir was only received by 3 patients in the entire study. So the primary outcome was mortality, and it was lower in the dexamethasone group, which was really surprising because everything that we suspected so far was that in coronavirus infections, dexamethasone, or in fact any steroid, might not be of benefit. And the reason we thought that is there was some work from MERS that suggested that it might prolong viral shedding, and also similar kind of suggestions that it might be disadvantageous coming out of the SARS-1 epidemic that occurred some years ago. When they looked at the different subgroups of the patients that were receiving therapy with steroid, they found that actually this mortality benefit wasn't present in all the subgroups. So it was strongly present in people who had invasive mechanical ventilation, and it was present in people who received oxygen. But as you can see from this forest plot, actually the people who weren't receiving oxygen, there was no benefit and possibly even a trend towards harm. But the overall study showed that there was a benefit from dexamethasone. When this was announced by press release, the very next day, the chief medical officer wrote to all hospitals and suggested that we should be using this therapy immediately in all patients who were hospitalized who were receiving oxygen or invasive mechanical ventilation. So it overnight became standard of care for COVID in the UK, which was very controversial because that was made on the basis of a press release rather than any of the data being available. But the data, or the preliminary data, and no late outcome data, but the preliminary data is available from the New England Journal currently. Remdesivir has been similarly controversial. So a paper, there's been several trials of remdesivir, two particularly based in Wuhan, neither of which actually recruited to target, and both of which were suspended and then terminated for failure to recruit as their pandemic died down. And they were both funded by Roche, the makers of remdesivir. But then there was this study in the United States funded by the NIH looking at remdesivir, which they've produced a preliminary report, again in the New England Journal for. And essentially it was a double-blinded placebo RCT of intravenous remdesivir in hospitalized adults who had COVID and, importantly, lower respiratory tract involvement. They did not enroll anybody into this study who did not have respiratory symptoms. And as you will know, that's not everybody who presents with COVID to hospital. The intervention was up to 10 days of remdesivir versus placebo, and the primary endpoint was switched about 6 weeks before the trial was reported, but probably wasn't a significant methodological impact on the overall data that came out, but they were fairly open about it. The endpoint in the trial, as it was reported, was the time to recovery, and 1,063 people were randomized. And the headline result is this, and it's a somewhat overwhelming, or underwhelming rather, result probably, but what it suggests is that the time to recovery was reduced in patients who had remdesivir. Now, the time to recovery is the time to either leave hospital or be found fit to leave hospital. And if you might just be waiting for further care or other settings or something to be arranged, but to be deemed medically fit to leave or have left. And it reduced by a very small amount, but it was statistically significant. This is fairly early data. They haven't got they haven't reported the long-term follow-up data yet, apart from the fact they have the data, but it's not in the public domain. But on the basis of this, the MHRA gave emergency authorization via an EAMS process in the UK for the use of remdesivir, and actually now it's gone and had further regulatory approval for use in hospitalized adults with COVID-19 in the UK. Initially there were some restrictions around it, but most of those have been lifted. One of the restrictions around it, given that this is a renal meeting, is that actually no one who was on renal replacement therapy or dialysis was included in the trial. And there are suggestions that actually it may not be brilliant for your kidneys from some of the trials in Wuhan, although they got nowhere near completing. So the data are really not fully available for that. And not all of it's in the public domain. But in patients who have either acute or chronic renal dysfunction, there is a certain amount of caution about remdesivir. The creatinine clearance cutoff was actually people who had a creatinine clearance of 30 or less were not included in any of the trials, and some of the trials actually used a cutoff of 50. So I think for renal patients, there's still a big question mark over remdesivir. Anti-IL-6 therapy, I think, has been one of the most controversial things about COVID. Early on in the Wuhan initial outbreak, there were some papers that were published that suggested that there was an enormous cytokine storm in patients who were having COVID, who were extremely unwell, and that the IL-6 was prognostic, and therefore the idea that we should potentially use anti-IL-6 therapy as a treatment to make people with cytokine storm better arose. I think what I would comment here is that actually, when you compare the patients from Wuhan with people who actually had pre-COVID ARDS, their IL-6 levels are about 10-fold lower than those patients. And they're not significantly high by ICU standards. And we're also not entirely certain that it's quite as straightforward as there is a raised IL-6, I will therefore give them an anti-IL-6 therapy being the way forwards. And this has proved to be the case. A lot of people have been given off-label or outside of the clinical trials anti-IL-6 therapy, and those therapies are not faring quite as well in the trials as I think was initially thought. The saralimumab trial in the United States was terminated early for futility, and then Roche, who are the makers of tocilizumab, had their own phase 3 study, Covacta, for which they've not published the data, but because it affects their share price, the moment they had it, they had to issue a press release. And the Covacta trial showed that anti-IL-6 therapy tocilizumab did not meet the primary endpoint of improved clinical status in people with COVID-associated pneumonia, and it didn't meet the secondary endpoints either. And I think if we were hoping for a positive result, it's probably most likely that the drug company's own study would have been the one that would give it to us, and it didn't. But the recovery anti-IL-6 tocilizumab is still recruiting, so we will get additional evidence to give us a really robust answer about whether we should be using this therapy or not. But I would strongly encourage you not to be using it outside of clinical trials. Then convalescent plasma. This has been all over the news in the last week, not least because on the basis of this, the FDA, with some statements also from Donald Trump, announced that it saved lives, and that for every 100 people who had COVID, if you gave them convalescent plasma, 35 of them would live. Thankfully, that statement, which is incorrect and not based on data in this paper, despite them claiming it was retracted earlier in the week. And what this observational paper from the Mayo Clinic showed was a registry of about 37,000 people who were enrolled and given convalescent plasma as part of therapy for COVID. And when they looked at those patients and everybody who received at least one dose of convalescent plasma, in a subset of them, so about 35,000 people actually got 1 unit of plasma. In less than 10% of those, they'd managed to get retrospectively a measurement of how much antibody was in the plasma that the patients were given. So in 3,000 there or thereabouts patients, they came up with some cutoffs for high, medium and low antibody titers. Rather than using them as continuous variables, they grouped them into those 3 groups, and then looked at what they thought the outcomes might be. And there was a 35% relative risk reduction between receiving high antibody titer, as they deemed it, plasma, and low antibody titer, rather than a benefit from treatment versus no treatment. But the absolute risk reduction was actually 4.8%. So what this paper showed was actually that there was a 4.8% risk reduction, so absolute risk reduction, if you had high antibody plasma versus low antibody plasma. There was no control group, so we have no safety reporting either. So we currently don't know whether there's evidence that this therapy is of benefit versus not having it, and we still don't know what the downsides are because, again, no control group. The other issue about this study was that during the course of this registry being set up, patients received an awful lot of other therapies alongside. Some got remdesivir, some got hydroxychloroquine, and a range of other therapies too. And unpicking that is almost impossible in a non-randomized, non-controlled study. So I think the jury is very much out based on this paper. But the UK studies, so Recovery and REMAP-CAP, which is an ICU-based platform trial, which are both testing convalescent plasma in the UK, should hopefully give us some data that's helpful by the end of the year on this. So what I hope I've managed to convince you is that clinical trials are essential, that steroids probably have benefit for patients receiving oxygen and mechanical ventilation, that hydroxychloroquine, lopinavir, ritonavir, and probably tocilizumab don't have benefits as we have data at the moment, and that we don't know about convalescent plasma or a whole range of other immunomodulatory therapies that are still under trials, and that the data for remdesivir is still a little bit uncertain.
Lovely. Thank you very much, Charlotte, for a nice run through the trials and some of the evidence there. That was really interesting. Thank you very much for bringing that all together. We've got one question for you about, is there any data about anti-IL-1?
So there have been some trials of anakinra, and the REMAP-CAP trial, which is an ICU-based platform trial, one of the arms is anakinra. They're having difficulties with the supply of the therapy to be able to do it at scale currently. So I think it's going to be a while before we get any strong results about that. There are some very small observational non-controlled studies that suggest that anakinra might work, but we also had very small studies suggesting that saralimumab and tocilizumab might work. So I think until we've got the actual data, it should be confined to being given as part of trials.
That's very helpful. Thank you very much. Thank you very much again, Charlotte, for that very interesting talk. Marlies, I'm going to hand over to you for the next talk now.
So the next speaker is John Murray, who's a consultant nephrologist at South Tees Hospital. And as you know, he has set up a lot of AKI initiatives. At present, he's chairing the AKI working group, which is a working group between critical care, the Intensive Care Society, and the Renal Association. And it really stems from our experience during the COVID pandemic, where critical care and the renal teams were working extremely well together and learned from each other. I'm afraid he is not present here at the webinar, but he's pre-recorded his presentation. And he will also take questions. If you type them in the box, we will send them to him and he will get back to you.
Many thanks for inviting me to present as part of this acute kidney injury webinar. My name is Jonathan Murray and I'm one of the consultant nephrologists at South Tees Hospital's NHS Foundation Trust in Middlesbrough. I'm also currently co-chairing a working group on behalf of the Renal Association in collaboration with the Intensive Care Society. The nature of this will become apparent as part of this presentation. The COVID-19 pandemic has revealed a critical national shortage of reserve resources needed to deliver kidney replacement therapy to critically unwell patients during such emergency states. Whilst concern focused upon critical care bed and ventilator capacity becoming overwhelmed during the early stages of the pandemic, it became clear that resources required to provide renal support for critically unwell patients was a concern of equal magnitude and clinical significance. Whilst NHS resources are configured to meet routine clinical demand to ensure responsible use of NHS resources, a further COVID surge or similar national emergency risks overwhelming critical care renal support capacity, and this represents a national patient safety risk. The pandemic has also demonstrated many strengths of the NHS, including collaborative, innovative and resilient working between renal and critical care multi-professional teams. Renal teams across the UK have assisted their colleagues in critical care whilst continuing to provide maintenance haemodialysis services for about 26,000 UK patients with end-stage renal disease. Similarly, critical care teams have provided renal support for critically unwell patients with end-stage renal disease when they are presented to hospitals without on-site renal services during the pandemic. Such collaborative working during the pandemic has highlighted potential opportunities to optimise and streamline routine care of critically unwell patients with renal failure, including within hospitals without on-site renal services. It is widely recognised that acute kidney injury represents an acute illness severity marker. It is thus not surprising that a pandemic causing severe acute illness will impact upon both critical care and renal service demands. Observational data describing AKI incidence and outcome amongst hospitalised patients with COVID-19 disease further affirms this. Worldwide reported AKI incidence varies between 0.5% in early single-centre reports from China to 57% in US centres serving high AKI risk populations. Much of this variation likely reflects different AKI definitions, patient populations and clinical settings. Hirsch and colleagues reported high AKI incidence using KDIGO criteria amongst a large cohort of patients hospitalised with COVID-19 in New York. Of note, they found relatively high levels of severe AKI and in-hospital death, aligning with COVID-19 disease being a virulent disease, especially when complicated by acute kidney injury. Whilst there are important caveats to comparing observational data between different populations and healthcare systems, benchmarking their findings against UK Renal Association AKI data from 2018 underlines why COVID-19 has imposed such huge demands upon renal and critical care services across the world. 53% of patients with COVID-associated AKI in New York reached peak AKI stage 2 or 3, and 35% died in hospital. This is compared to patients with community-acquired AKI and hospitalised in the UK during 2018, where 42% reached peak AKI stage 2 or 3, and 30-day mortality was 21%. It will of course be interesting to observe the impact COVID-19 has had upon AKI incidence and outcome in the UK, underlining a further utility of the AKI registry produced in the United Kingdom. Another study, also based in New York, aimed to investigate if any aspects of COVID-associated AKI are unique to the pandemic in terms of risk, course, or outcome. As this visual abstract illustrates, the authors compared observational data from hospitalised AKI patients with and without COVID-19. They benchmarked their findings against similar data from an historical cohort of patients hospitalised during the same period during the previous year, 2019, which was prior to the pandemic, of course. They found incidence of AKI amongst hospitalised patients with COVID-19 was more than double that observed in the historical cohort. Once again, AKI represented an acute illness severity marker associated with 34% of in-hospital deaths compared to 9.3% with COVID disease but without acute kidney injury. Adverse associations between COVID and AKI were again most evident amongst patients with severe or stage 3 acute kidney injury, which was much more common amongst patients hospitalised with COVID-19 disease. In-hospital death was 52% for these patients, compared to 20% amongst those with stage 3 AKI who were COVID negative. Renal outcomes were similarly less favourable amongst those with COVID-associated AKI. Of some interest, initial respiratory rate, white blood cell count, neutrophil to lymphocyte ratio, and LDH level were predictive of stage 2 or stage 3 AKI amongst patients admitted with COVID-19 disease in this population. The pre-critical care observational data that I have presented so far underlines hospital COVID-19 disease is associated with high levels of severe acute illness and AKI. Pathophysiology associated with COVID-19 also indicates why this disease frequently leads to severe AKI and multi-organ failure, as summarised here by Ronco and colleagues. Pre-renal hemodynamic disturbances and ischemic acute tubular necrosis are predominant causes of AKI, especially amongst critically unwell patients with multi-organ failure. Both renal hypoperfusion due to arterial underfilling, secondary to left ventricular dysfunction and/or vasodilatation, and also renal congestion secondary to right ventricular dysfunction associated with COVID-19 pneumonia may be implicated. Toxic acute tubular necrosis associated with rhabdomyolysis has been widely reported too. And it's also proposed that the kidney may serve as a target for organ injury in COVID-19 disease, because angiotensin-converting enzyme 2, the binding site for coronavirus, is highly expressed in proximal tubular cells and also podocytes. Inflammation associated with cytokine storms and lymphopenia likely cause AKI in the context of wider multi-organ failure. Similarly, endothelial disruption and microthrombi are proposed to cause AKI as part of a wider coagulopathy reported frequently amongst patients with COVID-19. Reports specifically describing AKI incidence and outcome amongst patients admitted to critical care may be more uniform in terms of AKI definition, as many use kidney replacement therapy as a surrogate marker of severe acute kidney injury in this setting. The caveat, of course, is that several factors influence whether or not a patient receives kidney replacement therapy during critical illness, other than just AKI incidence. Given pre-critical care AKI incidence and pathophysiology associated with COVID-19 disease, it is not surprising that many patients admitted to critical care consistently require high levels of renal support, as summarised in this table from the NEFJC website. UK ICNARC data confirms that critically unwell patients with COVID-19 disease frequently require kidney replacement therapy. It also confirms that these patients have extremely high mortality, peaking at 80% in April 2020. Furthermore, care for these patients frequently requires wider resource use. Patients requiring kidney replacement therapy who survive a critical care admission require prolonged critical care support and ventilation compared to those not requiring kidney replacement therapy. ICNARC data also affirms that COVID-19 disease is a virulent disease associated with higher mortality and kidney replacement therapy use when compared to viral pneumonias requiring critical care support between 2017 and 2019. Such national and international data underlines why COVID-19 surges would impose huge challenges upon critical care resources, including those required to provide kidney replacement therapy. In addition to machinery and consumables, kidney replacement therapy to critically unwell patients requires sufficient critical care level beds and staff, including staff trained and competent to deliver kidney replacement therapy in such settings. Such resource limitations during surge or crisis scenarios arguably also impose challenges to conventional delivery of optimal and evidence-based kidney replacement therapy. In order to develop kidney replacement therapy resilience for critically ill patients in the event of a further COVID surge, the Renal Association and Intensive Care Society put out calls to establish a working group with multi-professional expertise and representation from both specialties. It was clear from the outset that representation from critical care units without on-site renal services was imperative, as was the need to produce guidance within a short timeframe. The calls brought together 42 working group multi-professional members, including nursing staff, pharmacists, dietitians, technologists and clinicians from both specialities, including the National Critical Care Outreach Forum. The primary aim of this working group has been to produce national guidance to ensure kidney replacement therapy resilience across all critical care units in the event of a further COVID surge or similar national emergency. Secondary aims include the need to produce an inventory of therapeutic and operational options which together are generalisable and relevant to all critical care units, including those without on-site renal services. There's also a need to incorporate pre- and post-critical care management of these patients to ensure safe and quality care transitions and limit unnecessary use of critical care services. Finally, we recognise there was an opportunity to utilise revitalised cross-specialty relationships, multi-professional experience and learning to optimise and streamline patient care during routine and emergency states for these patients. This organogram illustrates the structure of the working group, which aims to align with service specifications being drawn up by the critical care and renal clinical reference groups. The three triangles seek to broadly represent all UK critical care units. Tier 3 units represent critical care units in hospitals without any on-site renal services, We placed these units at the top of our organogram because they are the most numerous and also cannot rely upon on-site renal assistance during a crisis situation. Tier 1 units represent critical care units that are highly integrated with an on-site renal unit, including provision of renal support during routine circumstances. Tier 2 units represent the interim, with renal services on site with potential to assist with renal support during a crisis situation. The working group is organised into 3 overlapping integrated work streams. The pre-post critical care work stream, illustrated here, aims to provide guidance to limit acute kidney injury risk and progression, and where feasible and safe, manage severe acute kidney injury outside of critical care. It is also producing guidance to underpin safe and timely discharge of patients from critical care units, and also between hospital sites. Together, this working group is thus aiming to limit unnecessary use of critical care resources during a further COVID surge, including within hospitals without on-site renal services. The intra-critical care workstream has worked closely with the first workstream to ensure guidance in and outside of critical care aligns. It is also producing guidance around how to limit and support patients with acute kidney injury once they have reached critical care. The kidney replacement therapy workstream has used examples of innovative collaboration earlier in the pandemic and wider worldwide experience to produce an inventory of critical care options, which together are generalisable across all 3 critical care tiers. Topics they have covered include kidney replacement therapy demand versus capacity modelling, optimal critical care access, optimal anticoagulation, different kidney replacement therapy modalities and prescription, and of course workforce planning and training. Themes such as education and training, safe and tailored prescribing and nutrition cut across all of the work streams. This slide, kindly provided by Elaine Bowes, who is one of the working group members, and Hugh Cairns, illustrates how the critical care and renal team at King's were able to sustain kidney replacement therapy for critically unwell patients early in the pandemic. The y-axis shows patient number, with the grey bars representing total number of patients admitted to critical care with COVID-19 disease. This arrow shows the cutoff for their capacity to provide conventional continuous hemofiltration for such patients. The coloured bars show how the renal team were able to help manage increased demand for kidney replacement therapy using combinations of peritoneal dialysis and intermittent hemodialysis or hybrid therapies. We aim to provide final working group guidance in the next couple of weeks, following appropriate review and endorsement. I want to finish by using this further organogram to illustrate where we feel our current and onward collaboration with critical care colleagues fits within the wider acute kidney injury specialist interest group. There are of course many commonalities between renal and critical care medicine, and COVID has highlighted and reaffirmed strong working relationships between colleagues working in these specialties. There is now an opportunity to harness such good relationships and consolidate good quality and streamlined care for critically unwell patients with renal failure. And there will be opportunity for the renal community to join with this, should any of you be keen to do so.
So thank you to John for the presentation. Clearly a fantastic showcase of what can be achieved and what we can do following this crisis, where renal and critical care had or learned to work together successfully to overcome the AKI burden. And the good thing is we're now learning from each other and take the work further. John is happy to take questions if there are any, and he will send the answers back to you by email. And I'll hand over to Claire again.
Thank you very much, Marlise. Right, and I'd just like to introduce, this is our last speaker this evening, and it is Dr. Tom Blakeman, who is a GP from Leeds and a lecturer at the University of Manchester. He was the co-chair of the Think Kidneys Intervention work stream, and he's also involved with the NIHR patient safety research. Sorry, Tom. And Tom's going to talk to us today about best practice for AKI within primary care. Thank you very much.
As Claire's indicated, I'm a GP in inner city Leeds, and have a transpennine experience. I'm also senior lecturer at the University of Manchester. And over the next 15 minutes, I'm going to outline some work that we've conducted through the RCGP to improve post-discharge care for people who have been affected by acute kidney injury. And to start with, to sort of put things in context, over the past few years, there's been a range of policies that are emphasizing the need for integrated care systems. And within this context, I think there are perhaps real opportunities for AKI to act as a driver to ensure safer transitions of care, particularly for high-risk individuals. As Donald O'Donoghue stated back in 2013, kidneys and kidney health provide an important marker for good clinical care. And he said on a BBC at that time, if we can get it right for AKI, we will get basic care right across the NHS. And I've held that in mind over recent years. What we have is some studies both in the UK and internationally show that people who have been affected by AKI experience potentially avoidable poor outcomes following hospital discharge. And this is both in the short term, there's evidence of high rates of unplanned hospital readmissions. 1 in 5 experience a unplanned readmission within 30 days. And there's evidence that 1 in 3 will experience an unplanned readmission within 90 days. Over the long term, the data also shows that sort of 1 in 5 will experience AKI again, 1 in 6 will develop chronic kidney disease, and 1 in 4 will sustain a major adverse cardiovascular event over the following year following an AKI episode. To reiterate some research conducted by Simon Sawney and colleagues in Scotland, AKI is a strong, consistent and independent risk factor for unplanned readmissions, particularly readmissions for people with heart failure presenting with acute pulmonary edema. To date, AKI quality improvement initiatives and their evaluations have largely focused on acute management in hospital settings. And I sort of argue, and sort of to improve outcomes, including hospital readmissions, it's probably now necessary to develop quality improvement interventions that straddle the interface between primary and secondary care. As a starting point, we conducted a quality improvement project through the RCGP, which became focused on improving post-discharge AKI care. The RCGP partnership was sort of comprised both NHS and NHR organisations. From the NHR, we had funding through the NHR Greater Manchester Patient Safety Translational Research Centre, as well as NHR Clark Greater Manchester. It had funding and support through the academic health science networks of Kent, Surrey, Sussex and the North East and North Cumbria. It had stakeholder engagement from Scotland through Healthcare Improvement Scotland and NHS Education for Scotland. And it really built on the work that had happened over a 3-year programme of work through the Think Kidneys programme. As a diagnostic sort of first phase, 24 general practices across England and Scotland conducted case note reviews. And these were looking at both how the primary care response to AKI warning stage alerts being generated in primary care, as well as sort of looking at how is care being delivered for people who've had an episode of AKI and post-discharge. 148 case note reviews were conducted across the practices, and these aim to sort of generate learning needs that led to sort of practices developing action plans of what they might do in from that learning that was generated. I won't go into all the detail, but a couple of key points that stood out was sort of there was identified a need for greater clarity to be required to determine the urgency of post-discharge follow-up. When should someone be seen? How early should they be seen post-discharge? And who should be seen sooner than others? There's also a sort of a lack of evidence and an understanding, building what Claire was saying earlier, you know, the lack of evidence that patients are aware of the AKI diagnosis and the associated risks. There wasn't real clear evidence that was necessarily being communicated. This then, sort of these findings sort of informed sort of our phase 2 of the RCGP quality improvement projects was really, our aim was to how do we develop guidance to ensure tailored and timely post-discharge AKI care. And some key principles that we sort of took on board in trying to develop guidance was the need to place an AKI diagnosis in clinical context. You know, you need to place AKI in the context of people's other existing comorbidities. You need to place it in their social context. And in doing so, and a mantra that was there within the Think Kidneys program, the importance of treating the person, not a test result. Another factor that we needed to take into account was sort of the concerns of too much medicine. How do we maximize the clinical utility of an AKI diagnosis, whilst at the same time minimize information and overload and burden for patients, carers, and healthcare professionals? And the third point is that we wanted to develop guidance that was grounded in an understanding of routine practice. And in doing so, that we developed some guidance that relevant to support decision-making in practice across the interface. And in doing so, we've developed this engagement with primary care professionals in this approach. Our approach that we took to achieve this is that we use what we call established and rigorous RAND consensus methods. And for those of you interested, sort of the methodological approach taken is outlined in a paper that we've recently had published in BJGP Open. To go into sort of a few steps that were involved, we first established an RCGP AKI working group, and this is to span across the interface. So we had representation from general practice, primary care. We also had representation from nephrologists representing secondary care and acute physicians. And in the centre we have Stephen Campbell, who's an expert in RAND consensus methodology, and also is a lead for patient safety research in primary care and also across the interface. Our next step was we identified existing local, national and international guidelines that related to acute kidney injury, and we saw where they related to post-discharge care. And the next point that we sort of took is that we looked at actually, how do we place AKI in context? What we don't want to do is create a guideline that competes with existing guidelines. And this is particularly relevant where we'd recognize that a large proportion of people that were experience or sustain AKI have complex health and social needs. So we looked at sort of guidelines and what discharge care related to for people who have experienced sepsis. What are the guidelines that are related to people who have heart failure? What's in the guidelines for people with chronic kidney disease? And then as an NHS priority, how does this fit in relation to the care and guidance that's been recommended for the identification and management of people with frailty? We then sort of drew on these guidelines and we developed clinical scenarios for rating. And these took into account patient-specific risk factors, the severity of an AKI episode, and the degree of kidney recovery. In terms of patient-specific risk factors, we focus on people who've got heart failure, pre-existing CKD, cardiovascular risk factors, and evidence of frailty or vulnerability. And we generated a whole range of scenarios for rating by panel members. And the panel members were to ask for each of these scenarios, different patient populations, to determine if and when it's appropriate to conduct a medication review from the point of discharge. When is it necessary, and when should it be appropriate to recheck kidney function? Also, when should we be assessing proteinuria? This is the aim to sort of try and look to develop tailored and timely post-discharge care. We formed and recruited panel members to test these, rate these various scenarios. And we had representation from renal medicine, acute medicine, and routine general practice. In renal medicine, we had kidney doctors and AKI nurse specialists. And from general practice, we had GPs who were interested or had concerns around too much medicine and overdiagnosis. Those that are involved in heart failure work in their local practice and in the local hospital. And GPs that also had a pre-existing interest in acute kidney injury. We then sort of asked them to rate these 819 clinical scenarios. They initially rated them at home, and these individual ratings then formed a discussion at a face-to-face meeting in Leeds last year. After this discussion, panel members are then asked to rate these scenarios again. And we use the data from the second rating to sort of seek and identify where consensus existed. And this rating process helped inform the development of guidelines. And we developed very early drafts, and then we shared them with various stakeholders to ensure that we're building something that has engagement across the interface of care. So we presented some of this work at UK Kidney Week last year in Brighton, and we then sought feedback from representation from the UK Renal Association, the Renal Pharmacists Group, Royal Colleges and Societies, including the British Society of Heart Failure, Society of Acute Medicine, the Primary Care Cardiovascular Society. And we also sought feedback from the Patient Carer Participation Group at the RCGP and the Overdiagnosis Working Group that's led by Margaret McCartney. Finally, this led to sort of some publishing guidance, and we published that towards the end of November last year. And this is very much a platform. It's a starting point. It has face validity, and it's a starting point to look at when, to give some guidance of when someone should be seen, and looking at clinical review and sort of tailoring and making this more timely in the primary care response. Alongside this, we sort of had some recommended top tips that sort of highlight to sort of guide people what to do when they're considering AKI at the point of discharge and when they're being reviewed back in the community. And these base largely on existing guidelines, and they also refer to work that's been done and built up through the Think Kidneys program. I won't go into detail on sort of each of the recommendations today, but they're signposts and they're accessible on the RCGP website, the Think Kidneys website, and I think through the partner organisations of the RCGP project. A couple of the top tips that may be worth highlighting is really just emphasising, and some things that are probably already known, but emphasising that through this process, really the need to organise clinical review for people who are at higher risk. Sort of the need for arranging clinical review post-discharge for people with heart failure within 2 weeks, and organising earlier review post-discharge within 3 days for people with history of heart failure, have had a severe AKI, and have poor kidney recovery. And one of the points that came through the stakeholder engagement was really for hospital teams to beginning to coordinate that, and the opportunities for hospital teams to ensure that is coordinated and arranged before discharge, so that actually, particularly for patients where there are clinical concerns or risks of delays. In terms of ensuring an accurate discharge handover, some of the things that came from the RCGP case note reviews and the stakeholder engagement was recommendations that hospital clinical teams should have a process in place to confirm or refute the AKI diagnosis prior to discharge. Some of the GPs that were conducting the case note reviews, and they looked into the hospital system as well as their case, the medical records in general practice, they're finding, was it actually AKI in the first place? What was going on here? And I think sort of anything that creates clarity from the point of admission moving forward reduces some of the noise, and actually might seek to then ensure engagement and buy-in to the AKI as a relevant diagnosis, particularly going forward when people are back into the community. One of the other recommendations was to support continuity and determine urgency of follow-up, was the information to communicate to GPs around AKI stage and the reasons for the AKI, the degree of recovery at point of discharge, points about having values of baseline and discharge serum creatinines. Is serum creatinine stable? Is it improving at point of discharge? And a key point, and it's in across the top tips recommendation, is sort of clarity on medicines, and particularly medicines of cardiovascular prognostic benefit. Being explicit of what are the next steps, what has been stopped, what needs to be restarted, giving some guidance of the next steps post-discharge. And the other point, referring to the case note reviews, is around sort of evidence that communication has happened with patients and carers, so there can be that consistent message that Claire and Claire were referring to earlier. Just reiterating that point about heart failure with AKI, the need for early clinical review, It's associated with high rates of unplanned readmission, and sort of linking to the national guidance that was published in BMJ Heart last year, that clinical assessment is key. Looking at volume status post-discharge, you know, is relevant. Looking at weights, assessing someone's volume status. And that point that's made in the BMJ Heart paper, if edema is due to heart failure, diuretic treatment to correct congestion is justified even if it causes a rise in serum creatinine. And allowing GPs to be aware of, not get too preoccupied necessarily with the AKI diagnosis, and treating the person, not the test results. And that other point really about coordinating with heart failure teams, particularly where there's been medicines have been stopped or doses have been reduced. So really the work to date is a starting point. It provides a platform. Through the RCGP project, we developed an RCGP AKI toolkit, which has had reasonable levels of engagement. Since the post-discharge guidance was published end of November last year, about 350, it's been accessed about 350 times a month. The toolkit's been accessed over 7,000 times in the last couple of years. So there is a level of engagement and interest in this. In parallel to the RCGP work that we've been doing, through our NHR Clark funding, we also conducted a quality improvement project in Bury CCG. And this, the 31 practices in the CCG were incentivized to participate in audit and feedback activity, attend and participate in a multidisciplinary educational event, leading to the development of practice level action plans. I think one of the findings from that is that it is possible to engage general practice and practice teams in AKI and its relevance. Some of the findings showed that diagnostic coding post-discharge did improve, and that improving diagnostic coding was associated with improvements in medication reviews, kidney monitoring, and communication with patients and carers post-discharge. Some of the qualitative interviews that we did around this showed that this was enabled through the development of practice protocols and also the role of practice pharmacists. And there may be a workforce to embed into work going forward. So I'll end here, maybe points for discussion and sort of how do we embed AKI quality improvement within and help drive integrated care systems? What's the scope to ensure there's patient stakeholder engagement in this process going forward? How do we develop robust quality indicators that are relevant to transitions of care, both across the interface between primary and secondary care? And if we're developing these robust quality indicators, how do we embed them into an ACARE quality improvement around transition of care into existing infrastructures, such as GIRT, such as the QOF quality improvement domain of the new GP contract, and also through Think Kidneys KQIP. So returning to Donahue's point, I would sort of say, I would argue, and still the point, that AKI can act as a driver to drive high quality care across health systems. And if we get it right for AKI, there is the potential we can get basic care right across the NHS. So thank you for your time. We welcome wider engagement in the special interest group, particularly around this interest, of the interface between primary and secondary care. Just to acknowledge that some of this work was supported by NHR funding. So thank you for your time, and if we have time, welcome any questions.
Thank you very much, Tom, for again another very interesting talk and run through there. I don't think we've actually got any more questions that have come out, but I suppose what's interesting is it's all about care of AKI, patients with AKI. It's all about collaboration. It's all about communication, both between healthcare professionals, but the teams of healthcare professionals across the settings, and between the patient and the healthcare professionals as well. And that's been brought out in all the different talks that we've listened to this afternoon. I suppose since there are no actual questions that have come up, it probably leaves it to me to actually say thank you very much to all our speakers this afternoon, and thank you for everyone who's participated and listened and joined in and listened to the talks this afternoon. And I hope you'll all agree that it's been quite thought-provoking, and as usual we've had lots of different sets of talks that have all sort of complemented each other about communication and collaboration. AKI care is multi-professional, and it is across the different sectors. So as I've said, communication is key between care settings and between the patient and the healthcare providers. And what we can achieve by collaboration is quite amazing. And so we've been showcasing that, I suppose, recently with the COVID situation, about how we can cross those boundaries and help with the care and improving care to our patients. And hopefully with the different groups that have been set up recently with the GPs and with the across ICU and the Renal Association, we can help to smooth across the boundaries of the patients moving from different sectors and across from primary to secondary care as well, and help really improve the care of those patients. So unless Marlies has got anything else to add to that, I think I would like to say thank you very much to everybody for joining today. And as we've had the slide, Sarah's put up the slide about CPD credits have been applied for, and certificates of attendance will be issued and sent by email once the credits have been confirmed. So thank you very much to everybody for enjoying it. It's been a very pleasurable evening, and we've learned an awful lot, and I've certainly thoroughly enjoyed it. So thank you very much all. Goodbye from everybody. Bye-bye.
Thank you to the Renal Association and British Renal Society for organising this webinar and getting a fantastic group of speakers together. Thank you.
Thank you. Thank you, Marlies. Bye-bye.